Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing a case of septic arthritis that was diagnosed and treated from our department.
Sure.
So basically, a 73-year-old male was brought to ER with complaints of bilateral knee pain and swelling along with history of fever. So initial 10-second assessment, patient was conscious, oriented and speaking relevantly in full sentences. Coming to airway, his airway was patent. There was no secretions and there was no airway compromise at that time. Coming to breathing, his air entry was bilaterally his chest movements were bilaterally symmetrical. He had adequate chest excursions, had a respiratory rate of 20 per minute and saturation of 98% in room air. Air entry was bilaterally equal and there were no added sounds.
Okay.
Coming to the circulation part, patient had a blood pressure of 150 by 90 millimeters of mercury and had a pulse rate of 90 per minute and all the peripheral pulses were well felt. Coming to disability part, patient's GCS was 15 on 15 and pupils were bilaterally equally reacting to light.
Okay.
Coming to the exposure part, patient had a temperature of 90 degree Fahrenheit and had a GRBH of 195 milligram per deciliter. So at the end of the primary survey, we also asked for the pain because he had complaints of bilateral knee swelling. So he had complained of a pain score of around 5 on 10.
Okay.
So at this point,
was it more on a single joint or bilaterally?
Bilateral knee joint, he was pain. He was complaining.
Okay.
So after this, since he had only thing to intervene was pain, so we had asked to secure an IV cannula. A 20 gauge IV cannula was secured, and after confirming that he is not having any allergic reaction to paracetamol, 1 gram of IV paracetamol was started to him.
Okay.
So by this time we went with the secondary survey and ample history. So patient basically has no previous history of any drug allergy. He is a known case of diabetes, hypertension, bilateral osteoarthritis of knee. Then also has CKD baseline created 1.8.
Okay.
And the bilateral osteoarthritis of bilateral knee joint, he had underwent aspiration from the right knee 5 times previously. So this is the background history. So coming to the medication, he is on Press XL 25 mg once daily. Then he is on Febujet, that is Febuxostat. Then he is on Ditor and also some nephroprotective drugs.
Okay.
So coming to the history and events leading to the current presentation, 10 days back the patient had a history of some outside food intake, following which he had developed few episodes of vomiting followed by loose stools. And he also had fever at that time and was admitted in an outside hospital. So that time the patient had got persistent fever spikes and was started on antibiotics from there, and he also had some worsening of creatinine also at that time. After that he got discharged, but then he developed bilateral knee joint swelling along with pain, and the fever persisted. The swelling and pain was so severe, so that he came here for further management. And from the hospital he was admitted, he was already treated, started on with injection meropenem, then other symptomatic management with tramadol, paracetamol, all those things. And also they had done a joint aspiration, and in that the synovial fluid aspiration done showed more than 40,000 cells, and it was neutrophil predominant. Okay. So this is the basic history. So
okay, what are the differentials you're going to consider at this point with the current background of a viral, gastrointestinal issue also?
So basically, the patient had a GI sepsis, probably GI sepsis, following which he developed bilateral knee swelling and pain along with fever, and the joint aspiration showing a neutrophilic predominant, a sample with more than 40,000 cells. So it is high likely that it can be a septic arthritis, in a already pre-existing osteoarthritic joint. Okay. And a septic arthritis can be there. Or he is already on Febuxostat and all, so we don't know whether it is a gout attack also. But bilateral though unlikely, it can be a gout attack also.
Okay.
Then, or it can be a response, an inflammatory response to the sepsis. It can be an inflammatory reaction to the GI sepsis, something like a Rhesus arthritis, something like that. But that too, in the bilateral joints is unlikely.
Okay.
Then he had multiple joint aspiration history in the past, so it can be like because of that, when his immunity had come down because of the other sepsis, he might have got a septic arthritis due to that.
Okay.
So these are the DDs in our mind. So the first diagnosis for us is like septic arthritis in view of the outside synovial fluid report also. So we after making sure that his pain had come down, we went for the examination.
Good.
So basic a local examination, patient had no pallor, icterus, cyanosis, clubbing and lymphadenopathy. Patient had bilateral edema was there, minimal pitting edema was there. Then coming to the local examination,
pedal edema.
Pedal edema, minimal pedal edema was there. And coming to bilateral joint examination, local warmth was there. Then some erythema was there, and obvious swelling was there over the bilateral knee joint. So the patellar tap was positive, showing fluid collection in the knee joint, and he had range of movement restriction, on both, he couldn't do it by himself, and also with assistance also it was painful for him. So we didn't go much for a other movement examination, but he had pain on even flexing for around 30 degrees itself, he had complained of pain.
Okay. One additional thing, was there any breach of skin integrity?
No. No scars or sinuses, nothing like that was there. So this is the other system examination. His air entry, respiratory system air entry was bilaterally equal, and there were no added sounds. Coming to CVS examination,
and no other joint swelling was there?
No other joint swelling was there. Coming to CVS examination, S1, S2 was present, no other added sounds. CNS examination, he had no focal neurological deficits, and GIT, abdomen was soft, and he had no tenderness. So basically, from the secondary survey, we have a bilateral knee joint swelling with a positive patellar tap. So joint effusion is there, and with showing local signs of inflammation. That's erythema, local rise of temperature, and the swelling is there. With no signs of any sinuses or any pus discharge or anything. Obviously.
Was the patient febrile on presentation?
At presentation, he was not febrile.
Okay.
But
history of fever was there?
History of fever, and even within the first 6 hours in our department, he had again fever episodes.
Okay.
So this was the basic history and the examination finding.
Okay.
So we went with the further evaluation. So basically, we had sent for a complete blood count. So it had showed total count of 14,780 with a neutrophilic predominant, and he had a HB of 12 and a platelet of 299,000, and his CRP was 236, and he also had a procalcitonin of 2. Then coming to his other investigations, he had a deranged RFT. Already he had CKD baseline was 1.8. Now the creatinine was 3.9 with urea of 130, mostly showing the buncreat ratio was less than 20, mostly intrinsic renal pathology. Then his uric...
Was he given NSAIDs from outside, or?
Outside they had given him only Ultracet. History was only Ultracet was documented.
Okay.
So it is combination of paracetamol and tramadol.
Any other drugs in the background which might have contributed to?
He was given telmisartan from outside, so maybe because of that also some derangement, and sepsis background is also there.
Okay.
Nothing else. And his uric acid currently is 3, sir, but he is already on this febuxostat for it. Then other electrolytes were within normal limits. Then his HbA1c was 6.9, so almost within a control range. Then other examination, LFTs were within normal limit. So this was the basic blood picture, and so we had also planned for a knee joint.
Okay. Now you have this patient who has definitely proven history of like an infective foci, and we have very strong suspicion that the focus is towards the knees. And from outside labs itself, we know that the joint was aspirated and it was suggestive of septic arthritis. Okay, now the patient is with us. Hemodynamically, he is fine. Is there any role for any imaging at this point?
We can go for like a like ultrasound to know like if it is any localized abscess or like any collection, any pockets of collections are there.
Okay.
Then X-ray we have to definitely take because to rule out osteomyelitis.
Okay.
Any
Generally, in
involvement is
acute septic arthritis, there may not be much role of X-rays. Okay. But as you said, the chronic issues and bone things probably yes. But with knee, very limited use of X-rays. Ultrasound definitely yes. Anything else?
Then CT can be joint arthroscopy is like direct visualization. We have to go for arthroscopy. Then this MRI will give idea about the tendonitis or like synovium, that meniscal involvement.
If at all there is, we are going with an imaging, MRI might be the choice, but again very limited indication in this case. Okay, as you told, ultrasound probably yes.
So like this patient, basically he has that positive patellar tap, so we wanted to get a one thing is to relieve the pain. We should definitely go for a aspiration because the TENS fluid will worsen the pain. So one for like a therapeutic purpose and also diagnosis, we have to go for a aspiration. So this patient, we had done knee joint aspiration. Bedside knee joint aspiration, and the sample was sent for basically gram staining.
Okay. From the visual appearance, what all things you will be looking at in joint aspirate?
Sir, whether it is like clear, like stroke colored, or it is like a turbid, that
hemorrhagic.
Okay. Or hemorrhagic, then that viscosity, like it's thick or like very this thing. Then that like from obvious examination, these two things.
So did we aspirate both joints or only one?
Both joints. Both had this.
Both had similar appearance.
Then other thing is we have to send for the routine, like that is basically we have to send for gram staining. So if at all some organism is there, we may get, but there is high chance for false negative also. So in this patient, gram smear turned out to be negative.
Okay.
Then other thing we have to send is for the crystal studies.
Gram smear did not show anything.
Did not show anything.
Okay.
So other thing is
gram smear negative means gram negative, not that.
No. Gram smear.
Yeah, that's right.
Gram smear did not show anything except for some few inflammatory cells. Nothing was there.
Sure.
Then next we have to send this the crystal study.
Yeah.
So crystal study, like we can like very easily we can like pick up if it is because of some gout or any calcium deposits like that. But that also like sometimes we may miss due to sampling errors or delay in observing and all.
Okay.
So this patient, there was no obvious crystals under polarized study. Then
most important thing,
next we have to send this for the culture.
Total count?
Total count and then culture. Total count, this patient's, our study showed a total count of 8,500 cells. So outside it was like more than 40,000, now it is 8,500. So maybe because of, he had already received antibiotics.
And differential?
It was a neutrophilic predominant, like percentage, it is neutrophilic predominant. So maybe because of like treatment
receiving
already,
antibiotics,
he is on antibiotic, that might have come down.
Okay.
So basically if the total count is like more than 50,000 and all, it is high likely to be because of bacterial septic arthritis. And if it is like less than 5,000, maybe some inflammation, gout, all those can have few cells.
Okay.
So this patient, then we sent for a culture. So
right.
Culture turned out to be negative for this patient later. And other thing was he had like multiple history of aspirations, recurrent joint pain, all those history was there. So we had like given a orthopedic consultation because they any joint involvement is there, we had to know. So they had planned for a elective arthroscopy of knee joint for visualization and wash out of the pus. So in that also they had seen some synovitis like features and some collections which they had like washed out, but there was no obvious involvement of the bone or joints.
Good.
So after this, and along with that, we had also started him on antibiotics.
Okay.
So the antibiotics we had started him was like on IV meropenem and levofloxacin. After confirmed the creatinine clearance,
Okay.
we had started him on 500 milligram BD dose of meropenem
Okay.
and levofloxacin, like a start dose of 75 milligram, followed by 500 milligram once a day, like alternate day, once in 2
Based
days.
upon the clearance, fine. Yeah.
So like that we have started him on antibiotics and other like supportive measures were there.
Okay.
So after this arthroscopy and receiving antibiotics, he had started to like his inflammatory parameters, his ERP all had started to come down, and also his pain also had started to come down. So currently our plan is to give him a rest for the joints for like around 4 to 5 days. After that, to start him on graded exercise of quadricep strengthening and all those exercises, and later he can like be mobilized soon. And antibiotics wise, he may require like IV antibiotics, and later we can shift him to oral antibiotics. Maybe he might be requiring for like a longer period, like that around 4 weeks he might be requiring.
Okay.
Then apart from that, other like symptomatic pain management, all those things have to be done.
Okay, fine. So basically we will discuss other few points which we have missed so far. Okay. So once you are looking at septic arthritis, what are the most common risk factors kind of things you need to keep in mind?
One is like already injured joint, like
Good.
any history of osteoarthritis, any rheumatoid arthritis, trauma, any surgical procedure being done, then any history. Then other thing is like any hematogenous spread causing a septic arthritis. So IV drug abuse history, infective endocarditis, then any indwelling catheters, the dialysis catheter, all those things.
Okay.
Then diabetes and all those immunocompromised state definitely are risk factors.
Okay. So basically a direct inoculation or a hematogenous spread.
Hematogenous.
Okay. Fine. Any other diseases if the patient has, will the risk of septic arthritis increase or things like that? Okay.
That's osteomyelitis commonly. Sickling and all will cause osteomyelitis. This one thing is this gonococcal septic arthritis, gonococcal infections. So that is then
STDs.
Yeah. Fine.
gonococcal infection.
Okay. Okay. And after, not specific to knee joint, but post dengue, there has been a lot of reports of septic arthritis of late. Okay. Fine. Regarding usually what is the treatment from the antibiotic point of view, what is the empirical antibiotic usually advised for?
So
septic
common
arthritis?
causes of septic arthritis are Staphylococcus aureus. So if like a chance of MRSA is more, we have to start antibiotic covering MRSA, and also an antibiotic with a gram negative coverage. So we can go for a vancomycin. And if along with that a third generation cephalosporin, cefepime or cefazolin, all those things can be given. Then if renal dysfunction is there, instead of vancomycin we can go for linezolid, and some other drugs like flucloxacillin, minocycline, all have been like advised, but preferably vanco plus the third generation cephalosporin.
Okay.
So that is empirically we have to start. Then later, according to culture or like according to the response, we can de-escalate the antibiotics.
Okay. So, and usually this is one area where an IV antibiotic is preferred over oral for a longer duration of time. And though we don't have a very strong consensus of the duration of antibiotics in non-gonococcal septic arthritis, the general norm is to give IV antibiotics for 2 to 4 weeks, and the exact duration to be decided based upon what organism is found, what are the other comorbidities and things like that, and what was and wash given. So few other factors needs to be considered in deciding the final duration of antibiotics. Okay. So what has happened to this patient?
So this
far?
patient currently as I told, the arthroscopic washout, antibiotics, everything has been done, and today it is like post-op day like 5. So we had started him on graded movement of the joints, and his like inflammatory parameters are coming down. CRP all are decreasing. Fever spikes has come down. Like currently he is febrile for the last 2 days, and also his renal parameters are improving. Has a good urine output. Like that.
Okay, here we
And
have
his cultures like have turned out to be negative. His this synovial fluid culture has turned out to be negative.
okay. Here it is more of an acute kind of septic arthritis, so this is okay. But if the patient has kind of a chronic kind of arthritis, and we feel it's more of like an infective focus, what all the things you will keep in mind, especially in our part of the world?
TB.
TB should be ruled out. Then brucella. Then this chronic any trauma related previous any implant is there, it may have to be.
Patients can recurrently have hematorosis even out of trivial traumas.
Okay. For TB, like what are the common joints involved?
Vertebrae,
Spine.
spine, vertebral
Okay.
involvement.
Spine, hip, and the knee.
Hip.
Okay. Anything else?
So here, like since the knee joint,
Yeah, here it's more towards gram-negative from the history and with the history of aspiration with a GI symptoms before, and the patient has improved with the current line of treatment, both with arthroscopic wash and an IV antibiotic. The patient is improving, so we are justified in the current line of management. Okay.
if it is like anyway, like we have to go for aspiration, and we have to get a count. That is like the important thing.
Yeah.
And in joints like knee and all, we can like arthroscopy is like can be done like easily. But if it is difficult to visualize joints, then may have to go for like open involvement and all. So basically total counts of the sample with the culture, like we definitely have to go.
Okay.
And that antibiotic, IV antibiotic for like around 2 to 4 weeks should be like continued.
Okay. Right. Okay. Thank you.